Let's switch over our conversation now to healthcare, particularly the health of young children and newborns. And we're joined by a researcher at the KEMRI-Wellcome Trust Research Program, Dr. Jalemba Aluvaala. He's a post-doctoral researcher. He's here to talk to us about that. Good morning, Daktari.
Good morning.
Good to have you on the show.
Thank you for having me.
That is the hot seat of Kenya's biggest conversation.
Glad to be here.
Make yourself comfortable.
Thank you.
Look at that man there. His name is Siti Muga. He has the day's proverb. Asking for the proverb.
No, the proverb is something that anyone who sits on that seat has to enjoy. You don't need to ask for it. It's coming your way shortly.
Yeah.
One can claim to have many friends until they fall on bad times. It's a proverb from Uganda. Yes.
What do you make of that proverb, Doctor?
Well, I'm trying to recall what you used to do in school, like the apparent meaning or the real meaning. How does this one go? I'll start with either anyway. Well, I guess it speaks to fair weather friends, isn't it? That when times are good, that you'll have lots of people around you. Success has many fathers, so to speak, and not to. Yeah, but when you're in trouble, people don't like trouble generally, so people will take off. Yeah, so I guess that's
so essentially those are friends of your position, and not yours.
Yeah, yes.
Yes, it's your position. They are friendly too. So if that goes, they also go.
Yeah.
So you have different layers of friends: status friends, inner circle friends. Friends, blood thicker than water friends.
Yes, and those ones you only find out when you have problems.
Then you can start peeling them.
All the others present themselves as such. They present themselves as one unit. But please, have a rainy day and see how that works out. Yes.
I'll be there for you through thick and thin. Okay. Let's start with the thin. Then you see.
Yes.
Daktari.
Yes.
We've had several guests joining us from the KEMRI-Wellcome Trust Research Program. And thank you for being among them that have joined us. Today, we want to talk about taking care of children and newborns. Okay, so some people may say this is obvious, but just define those two. What's the difference?
Well, one falls within the other, obviously. So children, if you now want numbers, we generally, anybody who's less than 18 years old, I know the adult physicians may argue anyone who's less than 18 is a child, and then we have different ages and stages, as you call it. So for the newborn is any child who's between the age of 0 to 28 days. Yeah.
So 0 to 28 days.
Yes.
Now, it's important to take care of them when they're in hospital.
Yeah.
Okay. So you say yes. Why?
Well, so first of all, let me start off by just putting things into context in Kenya. So recent work, it's called the Demographic and Health Survey, which tends to look at what has happened over the last 5 years. So we have made progress in terms of health of our children, but there's lots of work to be done, and there's light at the end of the tunnel. So specifically, we do know that we are losing up to 41 per 1,000 live births of children aged under 5, and out of those, 32 are under the age of 1 year, and out of those, 28 are actually newborns. So that's just dealing with the deaths. So if you look at it in terms of just about 1.5 million babies are born every year. So if you do the math, we lose more than 50,000 children aged under the age of 5 annually, and more than 50% of that is actually newborns. And remembering that deaths is just the tip of the iceberg.
Yeah.
It's the final pathway of illness. And so we do know that usually before death is severe illness. And that's where hospitals come in, that we tend to see be at the knife's edge of severe illness in children. And that's why hospitals are a very important component of ensuring survival. And not just survival, we like to say for children, survive and thrive, because the primary business of children is to grow and develop.
Sure.
Yeah.
If we say that death is at the end of illness,
Yes.
and we're talking about newborns who are less than 30 days old, what severe illness, are we talking about that then has lived through and then ended in death for a human who is less than a month old?
Good question. So newborns are a very fascinating lot. Of course, I'm biased because this an individual who's spent 9 months completely dependent on mom, and then within a few minutes of birth, they have to transition from depending on mom to actually living for themselves. And in the process of that transition, lots of things can go wrong. And one of the things that commonly, the three main things that present us with challenges for this lot. One is babies who are born too soon. So babies who are born before term gestation, and if they're born before term gestation, what that means is that their organs are not ready to handle independent living. So the smaller you are, the more immature the organs, the tougher it is for them to survive by themselves. So that's the first lot. The second lot is babies who don't manage to breathe for themselves immediately after birth. And when they don't breathe for themselves, that lack of oxygen affects multiple organs, principally the brain and also the heart. And as a result, they can have challenges within the first few days of life. And then finally, they're coming from a protected environment. The immune systems are not very robust. So infections is another big issue. So those three things are the ones which present us with the biggest challenges in the first 28 days of life, especially the first week of life. Yeah.
Sounds like these things have started when the child is still in their mother's womb.
Well, some of them do, and you're making an absolutely correct point that it's not a pin drop process that immediately after birth, that's where challenges start. Some of these are actually because you can't separate mom from baby. So the health of mom has a huge impact on the health of baby. So that's why we usually say mother-infant dyad, and that dyad starts through not just during pregnancy. The health of young girls and women has an absolutely major impact on the health of children subsequently. Yeah, so I'd say you're absolutely right here.
When you have this discussion about newborns,
yes,
and then you talk about mortality, what really are we talking about? Are we talking about a failed health system? Are we talking about a lack of knowledge by the mothers of present-day Kenya? Are we talking about societal norms that don't seem to keep pace with what is necessary? What are we talking about exactly?
Yeah, so I like the multiple layers so it's like an onion. So there are multiple layers, actually, multiple factors that come into it. So starting right from the characteristics of that individual baby. So we do know the genetics have a role in survival. And then as you peel the onions around, what has happened to mom and what is currently happening to mom. So we usually say from a public health point of view, what are the things which are right close to that individual. But then as you go around them, as you correctly said, health system has a huge impact also. So when they have problems, how does the health system respond to their problems? Is it responsive? And if it's responsive, what is the quality of the care that we are providing them? So I would like to think of them as challenges, that we do have challenges in our health system that sometimes do not provide the care that is required in two ways. So one is the delivery of the care, the technical aspects of it. But then for us in pediatrics, we are family-centered. So there's also the aspect of the experience of care, both from the baby's and the mother's point of view, and the challenges in the family-centered care. Yeah.
Now let me ask this question. These are numbers.
Yeah.
Every year, how many pediatricians do our universities produce every single year in this country? And how many do we actually have currently?
So we probably have right about 500, like for a population of 40 million. Remember that more than half of our population is children. So there is a gap there. And in terms of production, like the institution I work for, University of Nairobi, we generally do about 20 to 25 every year. So across the country with other programs, we are the largest program in terms of training pediatricians. Probably say at maximum 35 pediatricians annually.
Okay. Yeah. And if we were to look at the 47 counties and talk about the distribution of these pediatricians, how would you say the distribution works out currently?
Yeah, so the distribution, just like lots of other things in relation to this country, is largely reflection of the socioeconomic status of the counties. So there's definitely a gap in terms of the places with the higher socioeconomic status have a higher number of pediatricians. And in fact, it is a good reflection of something called the inverse care law, in that those who need it the most are the ones who have the least, and those who need it the least have the most. So case in point, lots of us are actually in Nairobi and other large urban areas, but the bulk of children actually born outside Nairobi. But having said that, we also have to remember that even within urban areas, there is a huge need in terms of the urban poor. That's not just the rural population, that we do have needs which are masked just by the fact that this is Nairobi, for instance, or it is Nakuru or Eldoret. But within those regions also, there actually there's need which is not currently addressed. Yeah.
That is just question 1B. There's C, D, E, and F on the way. But let me ask this question.
Yes, please do.
I'm actually going in the direction I'm heading to is this. We look at the need.
Yes.
The majority of the people in this country still live in the rural areas. Yeah. Okay? So there's the discussion around access to healthcare.
Yes.
Okay, now, if we only have 400-500 pediatricians, not just doctors. Now, when you look at the issues that bring about this sad situation of this high mortality that we keep speaking of, are some of these issues that can be nipped in the bud? Meaning, at a primary level, you don't really necessarily need to have a doctor in place to be able to ensure that a preventative approach to this whole issue is actually addressed. And if that exists, how I know very well that you are then a member of the Kenya Pediatric Association.
Yes.
This association and those who work within it, because it is you who these things probably concern the most, if you're talking about the fraternity that you belong to. What is it that has been done, or what is it that has been planned to ensure that the care that is needed, I'm referring at preventative aspects, because the curative aspect is what points to big towns and places where there's money. Now, preventative is something that perhaps could be approached and could be achieved with greater ease. You are a researcher.
Yes.
You are a pediatrician. What do people advise and what do people do regarding this very same thing I've mentioned?
Right. So thank you for that question. So I think that allows me to bring out the whole aspect of how the healthcare system is organized. So as you've correctly said, there's that small aspect of curative, but for pediatrics and child health, that's where we have that term child health. We focus a lot on prevention and promotion. So looking at prevention and promotion, that principally should happen at the lower levels of the healthcare system, and using there's a connotation there which perhaps is not correct. It doesn't necessarily mean low in terms of low levels of care, but it's important. I would like to think of it as a foundation of the pyramid. So it's the lowest component of the pyramid, but perhaps the most important foundation. So we have two things, I think, which have gone as pediatricians, and having said pediatricians, remember that we don't work together, we are a team. So besides pediatricians, we have nurses, we have clinical officers, we have community health workers, and the prevention, I think one of the biggest tools we have in our toolkit is immunizations. Whereas there is room for improvement, I think we have done pretty well as a country, considering where we've come from. And I'll give the example of how this has contributed to the changing burden of disease. Like, for instance, the research group I work for, we have a network called the Clinical Information Network. So linking to get what happens at the community and what we see in the hospital, that 20 years ago, for instance, when I was training as an undergraduate, lots of the pediatric wards were full of children with pneumonia and diarrheal illness. But subsequent to that, there has been introduction of the new pneumonia vaccine, there's been introduction of new diarrhea vaccine, and we've seen an absolute shift from seeing those kinds of illnesses in the inpatient setting, and they have shifted to the outpatient setting, and shifted in the way that you're seeing less severe illness, which can now be taken care of an outpatient and at community level. And at community level, we do have a community strategy from both the Ministry of Health and the Kenya Pediatric Association is a strong component of various community health programs, which are geared to the common childhood, not just illnesses, but also interventions. Besides immunization, there's also breastfeeding. Breastfeeding is a major issue, so supporting breastfeeding at community level. And of course, children don't live in isolation, so water and sanitation also is a huge issue for us.
How are newborns and then children cared for? We're looking at the network, obviously, but then what then are we looking at that children are being cared for in facilities at that age today?
Right. What's our focus on right now is there's when they're in hospital, it's severe childhood illnesses. So, like I've already mentioned, the three common things that we observe for the newborns, but for the infants. So again, we still have the pneumonias. But there's work which is suggesting that the causes of those pneumonias are changing, and if changing from perhaps predominantly bacterial illnesses to other bugs like viruses, which suggests that we need also to start thinking about different ways of preventing, so perhaps vaccines for viral illnesses and that kind of thing. And besides that, we are in a situation also of, we call it a transition in both the demographics and the burden of illness, that we have experiencing a reduction in infectious illness, but also seeing in children more a rise in non-infectious illness. So, for instance, things like heart disease in children, things like following complications of preterm birth, the children who have neurological nervous system challenges, for instance, cerebral palsy. So we have lots more of that, both inpatient and also outpatient setting for our children. Yeah.
Before you can come back and look at the non-communicable. But like now, if you see that there's a drop in your infectious, whether viral or bacterial, there's a drop in that. Could that point to the obviously work that has been done and also the attention that is being paid to immunization? Would you see that is contributing to now the lower numbers?
Yep, certainly. I think the preventive measures there, so there are multiple facets to it. So when you have better nutrition, better immunization, and of course with the improvement in socioeconomic status, and so things at population, like for instance when you have smaller families, better spaced out families, and better circumstances for families, and especially mothers of childbearing age, that does have a huge bearing. They all work together to improving the health of the children. But for us, for instance, specifically, work we've done within the network and with our colleagues in conjunction of the Ministry of Health, one of the things that has happened also is having the best available evidence. So when this child at the bedside appears with a certain illness, that this is a common illness, what is the best way to take care of them? So I would give an example, for instance, of pneumonia. So we have had work that we've done within our network that has changed the approach to treatment of pneumonia with the antibiotics, for instance, and we've changed the types of antibiotics we use, and there's actually current work which is going on to look at the changing causes and also alternative treatments here. Yeah.
So then do you find, it's interesting, that is it that there is a prevalence of these non-communicable diseases in children, or that there are now children who are being presented to hospital?
So I think it's possible a number of things. One of the things is that with improving survival, then you'll start seeing children who perhaps would die earlier on.
Yeah.
And some of them, like I'll give a good example, is for the preterm babies, the very, very preterm babies, so who have challenges in breathing. So it does affect their lungs. And if they survive that early period, they will have challenges with feeding, they'll have challenges with their lungs not growing properly, and they'll be more susceptible to getting certain kind of viral infection. So that early mortality that was unfortunately preventing us from seeing them, that we now have to start getting prepared, that now we'll start seeing those children more and more in hospital. So that's an example of that transition. So when you do one thing well, then you now have to start anticipating that as a result of the success of your interventions, that you have to start looking forward, that what do I anticipate next in the next 5 to 10 years.
So there is the Clinical Information Network, which is a collaboration between the KEMRI-Wellcome Trust Research Program, the Ministry of Health, the Kenya Pediatric Association, and the Kenya Pediatric Research Consortium, and several county hospitals. So far, we have 27 county hospitals participating in this. So what do? You gather information. What kind of data do you collect in this network?
All right. So this network, at the core of it, is actually the patients at the hospitals and the healthcare workers. So what it does is that it brings together an approach you call learning health system. So what you want to do is to be aware of what is happening at the bedside, so that it informs policy and it also informs research. So that it's research questions that are clearly addressing the problems that clinicians and families are facing at the bedside. So what we do is that we collect information, so we call it routine information, from patients, our clients at the point of discharge from our facilities. So that's children and newborns. So their characteristics at the time of admission, the treatments they received, and then also the at the time of discharge, how do they fare during their inpatient stay, and what is their condition at the point of discharge. That allows us over time. So we have been at it for now 10 years to be able to tell that. So, like for instance, if it's neonates, babies who are born with below a certain weight, how is their survival changing over time? How is their survival different in different parts of the parts of the country? Yeah.
You know, just going back to the statistics that you've given us earlier, so we have 41 out of every 1,000 live births dying before they attain the age of 5.
Yes.
And a majority, more than 50% of these, are actually dying within the first 28 days.
Yes.
Now, you mentioned some things. What you've just talked about, neonates, the low birth weight is one issue. You've also talked about small for gestational age or they were born preterm.
Yes.
That means that at the point of birth, there's an issue already.
Yes.
Is the CIN able to detect this at the antenatal stage?
Yeah, so right now we are able to detect it at the point of admission to the newborn unit, but as you rightly said, that lots of the factors that determine outcomes come from the antenatal stage. So we do collect data about the antenatal experience, but this is from the time of admission. One of the areas which definitely we would like to move into next is to understand what's happening in the labor wards and also what's happening in the antenatal. Looking at moms prospectively and joining moms to the babies. But as it is right now, yes, we do have information about what happens to the moms. Did they attend antenatal care? What was their age? Did they receive the care they required? Did they have any obstetric problems like bleeding? Did they have infections? So we do have that information, yes.
You do have that?
Yeah.
I'll ask about that after the break. Okay. It's 8:30. Let's take a quick break. We have our guest, Dr. Jalemba Aluvaala. He is a postdoctoral researcher at the KEMRI-Wellcome Trust Research Program. We're talking about improving hospital care for children and newborns. Talking about those children, newborns, children born and within the first 28 days, newborns. And then we still talk about children all the way up to the age of 18. But of course, in the earlier stages of life, the under 5 mortality has been a global conversation. And this is what also has been informing the work that you've been doing.
This is the Situation Room, the only way to start your day.
Here to talk about improving hospital care for children and newborns. And he's telling us about the Clinical Information Network, which is a collaboration between the KEMRI-Wellcome Trust Research Program, the Ministry of Health, the Kenya Pediatric Association, the Kenya Pediatric Research Consortium, and participating county hospitals, 24 of them so far. You've told us that, yes, you've been able to now gather information and you can see what's happening at the point of admission of these children. And you are now able to actually start collecting data and drawing parallels. You've also been able to see that the mothers, you're able to collect data and see the mothers and how they were accessing antenatal care prior to the delivery ward. So what do you see? Is there any direct correlation between the mother's behavior and antenatal services and the chances of a child being born preterm or low birth weight or small for their gestational age? Is there any correlation?
Yeah. So we do know, yes, certainly there is a correlation, and we do as I mentioned earlier, that we do know that there are risk factors for adverse outcomes in the neonatal period, focusing on the maternal characteristics. So things like, for instance, age, moms who are very young, moms who are on the extremes of age. We do know that moms who have some conditions, medical conditions, for instance, if they have malaria during pregnancy, we do know that if you have some conditions specific to pregnancy, that if they have high blood pressure, and I'll take the example of high blood pressure. So it's very common, for instance, that you see that babies who are born small, who are born preterm, their moms would have, for instance, they had hypertension during pregnancy. Yeah, so certainly that mother-infant diet, we do say that you cannot separate mom from baby. So what's good for mom will definitely good for baby. Yeah.
Are there things that can be done then to make sure that the condition of the mom during these 9 months are actually so good that you reduce the chances?
Yeah, certainly. So not to encroach on the obstetricians and the midwife staff, but we do know from a public health point of view that's why you have the concept of the focused antenatal care, that all our moms should actually have antenatal care proactively when people are planning for pregnancy. When they get pregnant, they should have their evaluations. There's a standard package of care that you should have at the WHO. That does say 8 focused visits, and within those 8 visits, there are certain things which should be done to assess mom and to risk profile them and attend to any challenges that are identified, with the aim of taking care of both of the mom and also making sure that you're optimizing the growth of that baby, because that growth in utero does have an impact on the outcomes once they're born.
Baby's born. Is there a direct link between antenatal visits or lack thereof and the loss of life that we then see maternally or childlike?
Absolutely. So there is a direct link in 2 ways. I would say in 2 ways. That if moms don't attend antenatal care, they're also the same group which is possibly unlikely to attend, have skilled attendants at birth. And so if there's any complication from the maternal side and the baby side, then it does present challenges and you're likely to have bad outcomes. And then 2 is we have delays, the various models of delays in seeking care. So if mom has a challenge during pregnancy and that challenge is not identified early enough, and then they only present at the time of labor and delivery, then we have, like, for instance, if mom is at risk of delivering at preterm baby. So we have medication that can actually be provided to mom to help the baby's lungs mature so they don't have lots of problems breathing once they're delivered. So when that is missed out, then you are sort of like finding a situation where the horse has already bolted and you're trying to minimize. Yeah.
So a lot needs to happen at this point to make sure that all mothers are then attending antenatal care.
Absolutely. So we do have a concept. It's called the continuum of care. The RAMCA, if you know the acronym, reproductive, maternal, neonatal, child and adolescent care continuum. So it's a continuum across the life course. So from young girls to women of reproductive age, moms who are pregnant, to the children. So it's a continuum. And then within that continuum in the life course also has to be linkages within the health system, that you cannot have a health system that treats neonates in isolation, mothers in isolation. All those things have to be linked, and that's one of the things which we are really keen on in the CIN, using data to provide those linkages across the life course.
How far does it stretch, the CIN now? If we're looking at country footprint, Kenya, how far does that spread? Because I ask that because I'm trying to imagine that a lot of women still to date are giving birth. I don't know what the numbers are, but are giving birth at home under the care of who knows. So then if to say that the push then is to have as many women under antenatal care before they give birth, because then we can see the direct link between saving the lives of these children who unfortunately are passing. How far does it spread then to be able to get this information out there to say, look,
Yep. So our footprint right now, we are in 19 out of 47 countries, 47 counties. And in those 47 counties, we are currently working in 24 hospitals. So we are definitely not spread out across the country. But having said that, so there are areas of the country which we definitely would like to be in, but of course there's a resource constraint. But having said that, one of the things which we are working very closely with the Ministry of Health is that our network is working as an exemplar of what a routine health information system should be able to do, and we are working very closely with the ministry such that the ultimate aim is that the routine health information system running by the Ministry of Health, which also collects data from not just public institutions but also the other institutions, should be able to do what we are currently doing and use that information to support the kind of decision making that we're doing. And
Is we here the KEMRI-Wellcome Trust or Kenya Pediatric Research Consortium?
So it's a collaboration. So it's the we here is Clinical Information Network. So there is all the partners. So the KEMRI-Wellcome Trust, there is a Kenya Pediatric Association with its research arm, that's Capricorn, and then there is the University of Nairobi, and of course there is the National Ministry of Health and also the county government. So we work very closely also with the county governments, and like I said, the biggest partner is actually the healthcare workers, where the rubber meets the road and their clients.
Okay, let's talk about research, because you talk about data, you talk about research, you talk about gathering information about the very things that you're concerned about. Now, when you set about this process, there is a goal. Simple question: what will success look like?
So success will look like improving the healthcare of our children, and in a nutshell, that we'll have eliminated preventable deaths, and our children will be thriving. So they'll be growing the way they're supposed to be growing. They'll be developing the way they're supposed to be developing, so they're able to achieve their human potential.
Okay.
Yeah.
So clearly you have a timetable of sorts.
Yes.
By this particular period of time, we ought to have achieved this. We ought to see this. This ought to have changed. We ought to be in these counties where there's the biggest needs. Walk us through this and tell us, from the time you started, the changes you're seeing, the benefits you're seeing, and how far you are from meeting, say, the first set of goals you set, and what you hope to do to meet the second, and so forth.
Okay, thank you. So I'll probably start from the first objective. So the first question was, can we actually get good quality data from routine healthcare in our facilities? So I think we have answered that question, that it's possible to get good quality information. Next is what then can we do with that information? So what we've been able to do with the facilities, and that was one of our primary goals, is to actually, for healthcare workers at the facility level, to use that data themselves to improve the quality of care. And we have seen people working, so things that previously you'd call simple things that make a huge impact. So like, for instance, making sure that every child who's admitted in the hospital has a HIV test done, because that changes how they're treated. Every child who's very sick has a blood sugar taken. Every child who comes to the hospital, that we have clinical practice guidelines and says that this is the path you should follow, that you should use these characteristics to assess, classify, and treat. That we have been able to see that hospitals, and we are able to track over time performance in this evidence-based medicine, as we say, on a larger scale from research point of view. So I'll start off from the newborn side, because I have a predilection for the newborn. One of the things we've been able to do is we've worked very closely with the Ministry of Health to, from a health system strengthening point of view, to actually improve the information tools that we have at a hospital level. And that answers the previous question, that some of this data that we collect doesn't have to be within a research setting. So we have registers which are filled routinely by healthcare workers, and we do now have a register for inpatient newborn care, which previously was not available. There's a question of how do you introduce equipment. So quite often, remember, you are dealing with a baby at the bedside who has multiple needs, and the approaches previously was to buy equipment in silos, that we need to help them to breathe, so we buy equipment to help them to breathe. But we've worked with a program called NEST, using the data platform that we have to an innovative approach to introducing equipment as a package, that this baby requires to be kept warm, needs to be fed, needs to have equipment to help them to breathe if they have trouble. So to introduce equipment as a package to address the needs of the baby, rather in totality, rather than in isolation. For the larger children, one of the areas which I think the platform has been very useful. So at a community level, remember we asked about the community level. So in the high malaria endemic regions of this country, in the Western Kenya, so the introduction of the malaria vaccine, the pilot evaluation of after the clinical trials was done. So there was a pilot evaluation where Kenya is one of the sites. So the platform actually participated in Western Kenya, looking at when you introduce the new malaria vaccine in routine settings. So what happens in terms of from the immunization program point of view, and then in terms of the burden of disease that you're actually observing in hospitals, and you actually are able to show that it does significantly reduce the burden of severe malaria in hospitals, and that has informed the government's policy insofar as malaria vaccine introduction in the malaria endemic regions. And then final example, again for the larger children, I mentioned about alternative antibiotic treatments. So we have moved from, we do know resources are scarce, and we have to make a very clear choices on who needs hospital care. So we, based on trials, clinical trials done actually within the platform for a set of certain severity of pneumonia, we've been able to actually show that you can use oral antibiotics, which of course has the immediate implication that these children do not need to be in hospital, which has huge implications on family and resources and so on.
Yeah. So then what does the cost element look like for this kind of healthcare? Preventative in this case rather than curative, but usually then has a price tag attached to it. And for folks who would not be able to afford it on a regular basis, what does it look like? Of course, you want to invite the whole UHC conversation into all of this and say, would it then be possible to have mothers, pregnant in hospital at a nominal fee? Because whether we like it or not, what scares a lot of us from going to hospital is the cost involved. So you're going to stay home and say, there are a lot of mothers who would not be their first birth and say, well, the first and the second one were all right, so, I can sail through. But the cost element then discourages a lot of people from seeking this preventative care. What does that look like within the network?
So, so a very important aspect, and the financing is actually one of the key 6 blocks, as WHO says, of the healthcare system. So, whereas for the clinical information network, we are not working directly with costing. I do have to say that we have colleagues who are working very closely with the Ministry of Health, looking at, so like for instance, evaluating the Linda Mama program. They have colleagues who are actually looking at designing the packages that would be covered under universal healthcare. So I, as a pediatrician and epidemiologist, I don't have the numbers which a health economist would give you, but certainly there's lots of work with colleagues going on in that area.
Is there a reason why the clinical information network does not involve obstetricians and gynecologists?
I wouldn't say it's an exclusion. We definitely would like to be involved. So it's a reflection of the starting point that we started off from the child health point of view. So and it's a legacy of the research group that we work with. So we started off looking at child health, and the problems for the children within the units were such that we are looking inwards, and then now with the development or the improvement of things. With the priorities that we'd had then now we are at the point that now, yes, definitely, we need to start looking at not necessarily with CIN managing everything, but in a collaborative way that we do have from the obstetric point of view, that certainly that's an area we would like to work with. And having said that, I will have an example of collaboration now. We've also started working with the adult side of things, and that has a direct bearing on children, because we do know in our hospitals that children who are above the age of 12, for instance, do end up being taken care of by the adult physicians, and they end up in the adult wards in our public hospitals. So that's an example of how we as an exemplar of moving beyond the traditional pediatric population and working with other peoples within the hospitals.
What would it take to add OBGYNs into this network?
So it would take resources, definitely, because it's the collecting data has a cost element, that's definitely, but that's one part of it. The bigger part of it is actually engagement, because as if you look at the CIN, what it aims to do, the first thing is actually stakeholder engagement, because working with people is the most important element, and there's work going on both within the within the program, and also within our collaborators to working together with the other people in that space, like the COGS, the Kenya Obstetric and Gynae Society. So it's a work in progress, starting off from the stakeholder engagement.
To bring them on board.
Yeah.
You'll notice, Dr. that I'm focusing a lot more on the newborns.
Yes.
And going before birth.
Yes.
Right? Because you've told us the majority of the deaths under 5 actually happen in these first 28 days.
Yeah.
And that tells us a lot. That tells us that this child, by the time they're born, they're already predisposed to actually being admitted to hospital.
Absolutely.
So it's important that we think, okay, so how do we make sure that by the time the mother is going to the labor ward, the baby that they're about to be delivered of is actually prepared to live by themselves? Which brings me to the point of this antenatal care and the number of women who actually access these services, and then those that don't. It sounds to me that one of the things that you'll need is a lot of information and awareness for all mothers to know that it's a good thing for you to see a specialist or go through this program of antenatal care before delivery, and to understand why. And then bring in the community health workers and ask, how can we use the community health volunteers to do some of these basics? Testing high blood pressure, for example. How can you regularly doing the test of high blood pressure? Would that have an impact on making sure that by the time the mother is going to labor ward, then the child has a higher chance of survival?
Yeah, absolutely. I couldn't put it better myself. That I think what you're saying is that is a reflection of perhaps like what I was saying. The health system has to be responsive to the needs of the clients in a way that actually suits matches their problems. And like you're saying, the levels of the health system, it starts right at community level. So and what I would say is that the approach should be, what can we do with what we have? And there's still lots we can do without even necessarily putting in more resources. So we do need extra resources, but there's from the lessons we've learned with the CIN and looking at hospital level, what we've been able to do with available resources that the clinicians without so the CIN doesn't put in anything else apart from the data collection. So it's very possible to optimize what we have across the health system, addressing exactly what you're saying. So whereas we are not necessarily directly working with the maternal side, that's certainly the principle of it is we have been able to show that principle of optimizing available resources even before you put in more resources. And having said that, that also brings me to an example of even as you are investing, you have to have information to allows you to invest efficiently. So things like if it seems obvious that you need more healthcare workers, but you'd be surprised there's actually very little work that has gone into saying that if you're going to introduce health workers, so how many, what specialties, and that kind of thing. So
and where.
Right. So we have some work which we're actually doing at least from the newborn side of things, which is generalizable in the sense that at every level of the health system, that's a question that needs to be answered.
We've touched on the community health workers, we've touched on the nurses, the clinical officers, but there's this little detail of how these individuals are trained.
Yes.
You said you are at the University of Nairobi.
Yes.
Now, KEMRI is mandated to research, health research. How do you ensure that this thinking that we're discussing here is part of the training of the health care community, the providers of healthcare, so that it isn't just this small group that now comprises the CIN, but even as one goes through the process of learning and wanting to be a healthcare provider at whatever level, that they understand this, so that with every new output of people who enter the workspace, there is this renewed thinking that involves research, that involves the preventative care of, yes, units are taught, but the focus on it, so that what the findings you've had in research are actually put into practice as wholesomely as possible.
So thank you. Excellent question. So that comes to the human resource and training of the human resource. So the work we've been able to do is that, so it starts with with the regulatory bodies. So we do engage with the regulatory bodies very closely to inform our research work. And so one of the things we do, for instance, is when you're doing evidence synthesis to inform clinical practice guidelines, we involve people from the training institutions and also from the both medical and nursing and clinical officer councils, for instance, regulatory institutions. So giving concrete examples. So, for instance, we have a program for the newborn, training on using of equipment and essential newborn care. So that has currently been embedded in pre-service training, both at the university level, so when you're training medical doctors and nurses. So we do that training program, they do learn what is the current best evidence at pre-service level, so that when they appear at the service points, they're already aware of what is the best practice right now. And also at the Kenya Medical Training Center, so there's also that training has now gone into the pre-service level for the training of the nurses and the clinical officers. So the answer in short is yes, we have engaged training institutions, and we are working both at pre-service level and also working with the professional organizations at post-qualification on using a continuous medical education approach.
Dr. we thank you very much for joining us.
Thank you very much.
Very informative. Come again once you've gotten something more to share with us.
Absolutely, we have a lot. Thank you very much for having me. It's a pleasure.
Dr. Jalemba Aluvaala is a postdoctoral researcher at the KEMRI-Wellcome Trust's research program. He's been here to talk to us about improving hospital care for children and newborns.